She's getting mic'd up. And after this, we'll be talking about lunch, one of my favorite subjects.
Well, it's a pleasure to be here, and I don't know, I have two microphones. Is it okay with both on? Just leave it? Okay. So just a little bit of background. I'm a reproductive endocrinologist, so I trained in obstetrics and gynecology and then did subspecialty training and focus primarily on hormones across the lifespan for women. And a lot of that relates to reproductive problems and fertility issues. So just a little review so that you understand some of the process that I'll discuss later. So we know that in women, actually, and Dr. Turk is going to talk about men too, so a lot of the same hormones, but obviously function a little bit differently. But the pituitary produces this hormone called follicle-stimulating hormone, and that stimulates the ovary to produce an egg every month, and then that will grow and produce estrogen, and looking at it a little bit simplistically, then that tells the brain that the ovary is responding, and then as the ovary matures, or the egg matures, then in the middle of the cycle, LH is produced to cause ovulation, and then 2 weeks later, if the woman isn't pregnant, she'll get her period. When we're looking at women and trying to assess their fertility, one of the tests that we will do is a test of the FSH level. So if someone has done any fertility testing, they may have heard their doctor say, oh, let's do an FSH level. So if that level is low and in a normal range, then that is good for fertility overall. But as women age and as the ovaries don't function as well, that FSH level goes up very high. So a woman in menopause will have a very high FSH level. And if someone is coming in for fertility testing and their FSH level is very high, then that will be a poor sign for being able to get pregnant. We know that women with CF may have delayed first menstruation, so they may go through puberty a little bit later, possibly related, to their chronic disease and their lower BMI. And lung function does change across the menstrual cycle, usually probably related to progesterone levels, but it doesn't usually seem to be clinically significant. So in terms of pregnancy, the first successful pregnancy that we know about was in 1959, and the U.S. Patient Registry reported 225 women with CF who were pregnant in 2010. If you look at long-term health after pregnancy, the survival does not seem to be affected by having been pregnant. Obviously, during a pregnancy, there may be some little bumps, but if a woman gets through the pregnancy, if you look at her health a year or two later, it seems to be exactly where it would have been otherwise. Now, obviously, women do require more medical care when they're going through a pregnancy because it's an extra strain on the body. And the children may be at increased risk of being born prematurely or having a low birth weight. Most women with CF are fertile, and many of them may not need any type of fertility treatment to get pregnant. It's really important, though, in any woman, even if she doesn't have any underlying disease, to be as healthy as possible before getting pregnant. So anyone who's thinking about getting pregnant, I would suggest that she meet with a high-risk obstetrician before pregnancy to have that team in place. It's going to be a bigger team approach during pregnancy. And it's important to review medications. A lot of medications are fine during pregnancy, but we need to make sure that if there's some things that could be changed, that those are changed. If a woman is diabetic, she wants to be in as tight of control as possible before pregnancy. If she isn't diabetic, we will screen very early on because women are more likely to develop diabetes in pregnancy. And we just want to make sure that the woman is as healthy as possible. And genetic counseling is going to factor in the stages where a woman is thinking about getting pregnant. because she would want to have her partner tested to see if he is a carrier of the gene. So if the partner is a carrier, then there is this option of doing pre-implantation genetic diagnosis, and you may read about different acronyms. So sometimes you may read about screening. That usually applies to kind of a different subgroup of patients, and it is well proven to do this technique in patients with cystic fibrosis, and we have done this in our clinic. We do it more commonly when couples come in and are just found to be carriers. They do not have cystic fibrosis themselves and have no family history, but they, on screening, while they're trying to get pregnant, will find that they may be carriers, and then they will come in to discuss options of genetic testing. The way that PGD works is that we will take one cell from the embryo before transfer, and then we will transfer the embryos that are not affected. And just to review the reproductive process, normally what happens is the egg is released, and then fertilization occurs usually within 24 hours of the egg being released. Then the embryo floats through the tube, usually gets into the uterus about 4 to 5 days after ovulation, and then usually will implant around 6 days later. When we're doing something and we want to test the embryos and do the pre-implantation genetic diagnosis, we're going to be doing an assisted reproductive technology procedure. And any patient who's going through this, there's always preparation, making sure all the proper tests are done. So we test to see what the ovarian function is like. The state of California has regulations for infectious disease testing that needs to be done. And then we will stimulate the ovaries, collect the eggs, collect the sperm, put them together, do the fertilization, then do the testing, and then do the transfer. So that's just the overview. So I'm going to go through the steps in a little bit more detail. So first we start with stimulating the ovaries, and what we do is we give the patient the follicle-stimulating hormone that I talked about early on. So the patient learns to give these injections of the FSH, and they will do these injections usually for about 10 days. And in that 10-day period, they're coming in every few days to see how their ovaries are responding. So you can see this is a healthy ovary that has responded very nicely to the FSH injections. And each of those follicles hopefully contains an egg. We can't see the egg on ultrasound, but the little fluid sacs where the eggs grow will get bigger as the egg matures. And this is usually what the ovary will look like right before we do the egg retrieval. The egg retrieval is a fairly straightforward procedure. It takes about 10 minutes to do, and it's a needle. It's done using a needle that passes through the top of the vagina. So it's a small needle. There are no incisions, there are no scars, and when the woman wakes up, there's nothing to see. So again, it takes about 15 minutes in the procedure room. It's done with some heavy sedation, and the patient wakes up right away and goes home an hour later. In terms of side effects, the woman may have a little bit of bloating, a little cramping the day of the procedure. People who are working usually are able to go back to work the next day, so it's usually not a big recovery. And when we're doing the retrieval, we're collecting, actually let me just, so you can see that little test tube. So we're collecting the fluid in those little test tubes, and then we pass it to the embryologist who's sitting in the laboratory, and she's looking at this fluid under the microscope. And hopefully we see lots of eggs. So that's what the egg will look like under the microscope. And then there are different ways of fertilizing the eggs. If we're doing conventional IVF, what we do is add thousands of sperm in a dish with the eggs and let the eggs fertilize more normally. But if we're doing something like testing for cystic fibrosis, then we want to fertilize the eggs with this procedure called intracytoplasmic sperm injection, or ICSI. And with this, we take one sperm and place it directly into the egg. So you can see the picture in the middle shows the holding pipette on the left, and then the little pipette on the right has a sperm. I don't know if you can see it in there, but there's a sperm, and then that goes into the egg, and the sperm gets released right in the middle of the egg. This was initially developed for men with very low sperm counts, but we use it for a lot of other indications now. And when we're doing pre-implantation genetic diagnosis, we don't want a lot of other sperm around the egg because we don't want to have DNA that potentially can interfere with the results. This is what we hope to see the next day. So this is called a 2-pronuclear embryo, and you can see there's the DNA from both the sperm and the egg. And then several days later, the embryos will be at a stage where they usually have about 6 to 8 cells. So this is 3 days after the egg retrieval, 3 days after fertilization. Currently, this is when we usually do the biopsies on the embryos. Now, this is an area that is, changing as the techniques for testing the embryos is improving. There are a lot of changes that are going on in this area, but currently, we typically will biopsy the embryos at this stage. And what we do is we make a little slit there's a little shell around the embryo. So we make a little slit in that shell, and then we take one cell out, and then we send that off for the testing. And usually that testing can be done in 2 days. And so 2 days later, we'll have the result, and then we'll transfer it to the blastocyst stage. This type of testing is not quite as accurate as doing testing like at the time of an amniocentesis. We're just testing one cell, so sometimes we may not get a result, and there is a chance of misdiagnosis because there is only one cell. So if someone does have this testing, we still do recommend that they have testing during pregnancy, either do chorionic villus sampling at the end of the first trimester or an amniocentesis around 16 weeks of pregnancy. And this is the stage, and this is what the embryo will look like at the time that it's transferred. So 5 days after fertilization, it will be at the blastocyst stage. And at this stage, you can start to see the cells that will form the fetus and the cells that will form the placenta. The embryo transfer is not a very big procedure. We just take a little catheter and place it through the cervix into the uterus. That usually takes about 10 minutes to do. Usually patients don't need any sedation or anything for that. Most women say it's usually not too much worse than having a pap smear. It takes a little bit longer, but it's not usually a very big procedure. And then, the question when we get the results of the embryos is what to transfer. And typically, we're looking at the embryos on day 3, and if they look really good, we go to day 5. Now, when we're doing the PGD, we'll be looking at them at the blastocyst stage. And we grade them, and there's certain characteristics that we think look better, and the embryos are more likely to continue on. And in general, we do like to transfer just one embryo at a time, especially someone who has an underlying medical condition. We'd like to tax the body as little as possible. But sometimes if the embryos don't look quite as good, sometimes we may transfer two. But again, this is what we hope for. And this is a pregnancy at about 8 weeks of gestation. So after we do the embryo transfer, we do a pregnancy test about 2 weeks later. And then if the pregnancy test is positive, then we do the ultrasound a couple weeks after that. So we do all the initial monitoring in our clinic, and then the patient would get passed on to the high-risk obstetrician at that point. So something that I think most of us know but tend to forget is how important it is to think about pregnancy as soon as we're in the right place to think about it. A lot of women get caught up in their jobs, and if you have a medical condition, you may want to, obviously you want to focus on that, and you don't want to try to be pregnant if you're not healthy enough. But sometimes people lose track of time, and I just want everyone to be aware of how quickly the pregnancy rates go down as women get closer to 30 and then in their 40s. So this is for any population of women. Women are born with all the eggs they're going to have, and so at puberty, women probably have about 300,000 eggs. And women are losing hundreds of eggs every month. So even if they're on birth control pills or pregnant, they're constantly losing hundreds of eggs. And that actually probably increases to about 1,000 eggs a month as women get closer to 40. There's no way to stop that, and that's how every woman eventually ends up going into menopause. So the ovaries are constantly getting depleted, and the eggs are also aging. So it's really important for women to think about, their age also when they're thinking about getting pregnant, because we know pregnancy rates really will go down. And if a woman can go through this in her late 20s and 30s, it's much better. The likelihood of being successful as a woman gets into her 40s is just, it's going to be much smaller. So there are women who have been reported to be pregnant after having a lung transplant. And the recommendation is, that they should have some period of stability. We don't know exactly what that is, perhaps 3 years. And compared to other organ transplants, they do seem to experience more frequent rejection during pregnancy. So because of this, I have seen patients in my clinic who have elected to use a gestational carrier rather than be pregnant themselves. And this is always an option for someone who is just not healthy enough to carry the pregnancy. So the woman could go through that whole process that I discussed, the egg retrieval, and then the fertilization, the testing, and then the embryos could be transferred into someone else. So this was one of my patients who did not have cystic fibrosis. She actually was one of my cancer patients. And so the woman sitting on the couch had to have a hysterectomy, and so she couldn't carry the pregnancy. But before she got treated for her cancer, she froze embryos, and then when she was ready to have a child, her niece actually had the embryos transferred into her and became pregnant, and she had a healthy child. So gestational surrogacy is an option when the woman should not carry it herself. And the regulations for surrogacy do vary quite a bit from state to state, and also a lot of countries do not allow surrogacy either. So in the United States, California is a very surrogate-friendly state. A lot of people do come to California from other states because a lot of states do not recognize it. So it is possible to do this option. Now, all of these techniques are quite expensive, and most of the time, these are not covered by insurances. So in California, most people do not have benefits that would cover to do the testing for cystic fibrosis, or just to do even standard IVF. And surrogacy is even more expensive because there are more fees for compensating the surrogate. It is quite costly from a legal perspective, so that sometimes is a barrier. But this is an option, and for any woman or any couple with cystic fibrosis, there are a lot of ways of having a family, and so I've discussed a few of the ways that we may be able to help if someone wants to have their own genetic child. Anyway, so I wanted to leave some time for questions because I know this often brings up a lot of interesting issues.
Go ahead, Kate. Should be.
Thank you for the talk. I have a question regarding the IVF. When you use IVF, you are using mega hormones, right, to start the whole process.
Using what?
Mega doses of hormones for the. So how does it affect CF? Because I noticed my daughter is 22.
Right.
When she's on her period, regular menstrual cycle, her CF is, the symptoms are getting worse. she has increased sputum production, she has increased cough.
So the effect of the fertility hormones will depend a little bit on their underlying medical condition. I have stimulated many women with very serious medical conditions, and if medically they're not doing very well, we stimulate them with much lower doses than we do. I mean, there are a lot of tricks that we can do. So someone who doesn't have good renal function, we're very, very careful because those patients are at risk of developing ovarian hyperstimulation syndrome, which can be a very serious complication. So in these patients, we monitor them even more closely, and we tend to stimulate them a little bit less than we would someone who has completely normal function. But again, I've stimulated patients who had lung transplants, were waiting to have a kidney transplant, medically were not very healthy and did completely fine going through the procedure. So it can be done, but we do need to watch them very, very closely.
Hi, I just want to say thank you very much for your talk. I had my daughter Maggie when back in 1988, and in 1990 she was obviously almost 2 years old, and we wanted to have another child. And I live in Chicago, like I said, and in the Tribune that one Sunday, it was Easter morning, I remember, they were just doing a study on pre-implantation genetic diagnosis. I called immediately. They were taking parents of children with cystic fibrosis, Tay-Sachs, and Down syndrome, I believe. So I did go through the process twice, and I'm just letting anybody know if they would like to talk to me about it. I'd be happy to share my experience with them.
That's great. I think it really does help. If this is something you've never thought about, all of this technology sometimes seems a little overwhelming. Most patients find that it's not as big of a process or as difficult to do as they may have thought. And, I think it's just important that people are aware that this is an option. A lot of people find that, with everything else going on, they don't want to use these technologies, or the cost can be a big barrier. So that is a problem for a lot of patients. And so I think, groups like you, have some power to maybe get the insurance companies to think about covering some of these things.
Hi, I have a comment for the parents in the room and then a question for you. We have a daughter, my husband and I, who's almost 6 with cystic fibrosis, and we went through this process to have our second child. And I was 41, and it was successful on the first try, so that can happen. As well as we used the one lab in the country in Chicago, I think you and I have talked about this, that can test for 2 things using one cell. And so because of my age, whatever, we tested for Down syndrome as well, and there actually was one embryo that had Down syndrome. And all of our embryos, all 13, either had CF or were carriers, so statistically that was interesting. So similar to you, I'm open if anyone would like to talk about it. Ellie, they transferred 4 embryos for us, 2 boys and 2 girls, and typical for Ellie's personality, she kicked everybody out and stayed, and she's about to turn 3 years old. So Bob and I are certainly open to anyone that would like to talk more about that. My question for you is about the statistics for our daughter Maggie Faye and for others, as far as if when she gets married, if her spouse is or isn't a carrier. Statistically, what does that look like for them to have a child with cystic fibrosis?
So obviously all of you know that the detection for a carrier depends on the ethnic background. So we're able to detect the mutations that are found in most Caucasian populations, but there are other ethnic groups where there are mutations that we're not as good at picking that up. But if she marries someone and they do the testing, and the husband is not found to carry cystic fibrosis, then very, very unlikely that they would have a child with cystic fibrosis. And I think, she's young, so by the time she's old enough to have a child, they'll have detected, more mutations. So I think very unlikely. If she does have a partner who is a carrier, then, she'd probably have a 50% chance of having an affected child. And and the other 50% would be carriers.
Hi, I'm 34-year-old CFR and also have CFRD and have been sort of labeled brittle. And I just wondered if you could comment on the risks of CFRD, not only in general, because it's so hard to control sugars with CF, but also being labeled brittle. If you could just comment on the realities and risks of that.
So having diabetes is always challenging in pregnancy, and I'm assuming you're talking about in pregnancy, right? And it can take, a lot of effort to keep sugars in control. I mean, there are high-risk people who just specialize in women with very brittle diabetes in pregnancy. And, so there are a number of women who are in that category every year. So, you're going to be going to the hospital constantly. You're going to have very, very close follow-up. And it will be challenging, but it definitely can be done. Of the things that we deal with in pregnancy, that one is tough, but we can deal with that better than a lot of other things. So having brittle diabetes should not make you decide not to be pregnant.
Hi, I'm also 34 with CF, and I was curious if there's any information or data on the percentage of women with CF who've had successful pregnancies that conceive naturally without using in vitro or other types of fertility treatments.
I don't know the data on that, so I can't. I'm sorry, I can't answer it. Yeah. So probably, anyone who's thinking about getting pregnant should see one of the maternal fetal medicine specialists. Those are the ones that are following the patients as they get further into their pregnancy, and they usually are, the best at addressing that. But it is hard. I don't think that the tracking of the pregnancies is quite as good as we'd like it to be.
I'm a social worker in Dallas in the clinic, and first thing I want to do is make a comment on that. And I work with patients, children and adults, and what I tell the adults who want to have children who have cystic fibrosis, that the one thing that they need to really think about is their adherence. Because if they want to bring a child into this world, none of us know if we'll get hit by a bus tomorrow, but certainly with cystic fibrosis, they have to make a commitment if they're going to have a child to raise that child to 18 the best of their ability. And so that really means to be adherent. So I do discuss that with them. And then my other comment is just that from Texas, this is a very delicate discussion to have in terms of in vitro and deciding what to do. What I do is I just sort of say, I'm telling you all the options. It's your decision, but a lot more people in Texas opt for, or at least in Dallas, opt for, we'll just hope for the best. And I don't know, you're from California, so you probably have more of the opposite. I don't know what.
Yeah, no, thank you for your comment. And these discussions, are often very difficult. There are a lot of ethical issues, and, depending on someone's religious or cultural background, may not be comfortable with any of these techniques. But then there are also patients who, have difficulty with deciding what they would do if they found they were pregnant and had some problem with the pregnancy. So I think it's just important that people realize that there are these options, and many people may not feel comfortable or be able to do some of these techniques, but I think it should be part of the conversation.
And that wraps up our time. Thank you very much, Dr. Westphal.